Hello, I'm Dr. Steve Johnson. In this brief training, I want to clarify the difference between Socratic questioning and didactic disputing within Rational Emotive Behavior Therapy and discuss when each approach may be most effective. In REBT, disputing irrational beliefs is central, but how we dispute matters. There are broadly two styles clinicians use: Socratic questioning and didactic disputation. Let's begin with Socratic questioning. Socratic disputing involves asking guided, structured questions that help clients examine their own beliefs. For example, instead of telling a client that their belief is irrational, we might ask, "Where is the evidence that you must be approved by everyone? What would it mean if you were not? Is this belief logical? Is it helpful?" The therapist's role is collaborative and exploratory. The client does much of the cognitive work. One of the primary strengths of Socratic questioning is engagement. Clients often feel respected and involved. They generate insights themselves, which increases ownership. When clients arrive at their own conclusions, belief change can be deeper and more durable. Socratic methods are particularly useful when the client is psychologically minded. The client enjoys reflective thinking. The therapeutic alliance is still forming. The client resists being told what to think. However, Socratic questioning is not universally effective. Some clients experience it as frustrating. They may feel interrogated rather than helped. Others may lack the cognitive clarity, emotional regulation, or abstract reasoning capacity to benefit from extended questioning. In these cases, a didactic approach may be more effective. Didactic disputing is more direct and instructional. The therapist explicitly explains why a belief is irrational, illogical, empirically unsupported, or self-defeating. For example, you're telling yourself you must never fail. That belief is absolutistic. There is no law of the universe requiring perfection, and when you hold that demand, you create anxiety and shame. This style reflects Albert Ellis's original approach: active, directive, and sometimes confrontational. The strengths of didactic disputing include clarity and efficiency. Some clients feel relieved when the therapist takes a strong stance. Clients who feel overwhelmed may appreciate clear cognitive structure. Clients with high anxiety sometimes benefit from decisiveness rather than extended exploration. Didactic disputing can be particularly useful when irrational beliefs are rigid and repetitive, when clients intellectualize endlessly without shifting, when the therapist needs to model rational thinking explicitly in psychoeducational group settings, early in treatment when teaching the ABC model. However, didactic approaches also have challenges. Some clients perceive direct disputation as invalidating. If the therapeutic alliance is weak, it can feel confrontational. Clients who are highly sensitive to criticism may shut down. So the question is not, which style is correct? The better question is, which style is therapeutically indicated for this client at this moment? In practice, effective REBT therapists flex between styles. You might begin Socratically to assess flexibility, shift to didactic instruction to clarify theory, return to Socratic questioning to consolidate insight. There are also client variables to consider. Clients high in reactance often resist direct instruction. Socratic works better. Clients who feel lost and cognitively overwhelmed may respond better to didactic clarity. Clients with trauma histories may initially require gentler Socratic exploration to preserve safety. Highly analytical clients sometimes prefer direct, logically structured disputation. It's also worth noting that cultural factors matter. Some cultural contexts expect therapist authority. Others expect egalitarian collaboration. Rigid allegiance to one style is less important than clinical attunement. Ultimately, both methods aim at the same target: helping the client identify, evaluate, and replace irrational demands with rational preferences. The method is the vehicle. The goal is cognitive and emotional flexibility. As clinicians, our task is not to defend a style, but to serve the client. Thank you for watching. If this was helpful, consider subscribing for additional training on REBT and cognitive behavioral methods.